A very good morning to all of you. I think it's time, it's 9 sharp, and we shall be starting our Cardiology Symposium. Now, we have been holding this Cardiology Symposium for family physicians and GPs for more than 10 years. And it gives me great pleasure to invite all of you for this Cardiology Symposium, which, as usual, is the first symposium of the year. This is what we have been doing all these years. And this is conducted in collaboration with MMA Selangor. Thank you very much, MMA Selangor. And supported by Vitris. In case you don't know, I just found out it. Lipitor has been with us for 25 years and Novas 30 years. Okay. All right. So it gives me great pleasure to welcome Dr. Juliet Matthew, the chairman of MMA Selangor, to give us a very short welcome address. Thank you, Dr. Juliet.
Thank you. Good morning, everyone. And I've been warned that it has to be short. So I'm Dr. Juliet. I'm chairman of Malaysian Medical Association Selangor branch. And first and foremost, I must thank SJMC and the vibrant team under Dr. J.M. Maller for this opportunity. Cardiology, I believe, is a very relevant topic these days. And I dare say it's one that will never go out of style in Malaysia, isn't it? Right? So it's a topic very close to my heart as well. I lost my dad when he was very young. In fact, I'm older this year than he ever was. So I'm sure the participants here, with all that has been lined up for today, will be able to take home many pearls of wisdom and knowledge from today. So again, thank you, SJMC. Thank you, Dr. J. Maller.
The first topic is a lecture, and this is a very short lecture, Dr. Kanan tells me. Dr. Kanan needs no introduction, and he will be talking about, Doc, I'm having chest pain. How do I know it is not my heart?
Good morning, ladies and gentlemen. I know it's been 14 days since the start of the new year, but I think it's still early enough for me to wish you all a happy new year. Thank you, Jaya, for introducing me, and thank you for organizing this conference for all of us. Now, 2 days ago, Dr. Jayamala sent, our boss, Dr. Jayamala sent a message to all of us to be on our best behavior during this conference. So I'm sorry, none of my naughty jokes this time. I'm very sad, but we'll go on. She said, keep it short, but I think it has to be 20 minutes. In my book, 20 minutes is short because I usually speak for about 60 minutes. I was trying to get some local data, but unfortunately, I could not. And this is an article which came out in the Australian Family Physician in 2017. It states that about 1 to 4% of chest pain presentations to general practitioners are secondary to the effects of acute coronary syndrome. It also states that 15% of patients who are finally diagnosed with acute coronary syndrome have an initial review with a primary care physician. So this is an area of medicine which is important for all of us. Chest pain is challenging. It can be challenging for us to determine whether the cause is cardiac or non-cardiac, but we do not want to miss a cardiac cause for chest pain because the consequences can be fatal. A systematic approach to the problem will help us make a good diagnosis. Ischemic heart disease, aortic dissection, and pulmonary embolism are major cardiac causes of chest pain, which can have potentially fatal outcomes. Other causes include pericarditis and myocarditis. Of course, fulminant myocarditis can be fatal, as we have seen during the recent COVID pandemic. Non-cardiac causes are usually common, usually musculoskeletal. We see a lot of patients with costochondritis. Also, radiated pain from the effects of degeneration of the cervical spine due to cervical spondylosis can also cause chest pain. Now, a history, although frustratingly inaccurate at times and frustratingly non-revealing at times, remains vital in the initial evaluation of patients with chest pain. all of us continue to be surprised intermittently with gastric pain, which turns out to be ischemic heart disease in the final analysis. Now, every time I give a lecture like this, I'm reminded of a patient seen at the Asunta Hospital many years ago. This was a 50-year-old diabetic lady who traveled half the night to get some relief for her epigastric pain, which was diagnosed as gastritis. But repeated doses of antacids did not help her. In the early hours of the morning, she turned up at the emergency room of the Asunta Hospital, where a sharp-eyed medical officer did an ECG, and that showed an evolving acute myocardial infarction. So always remember epigastric pain. Sweating is an ominous associated symptom of coronary artery disease. In patients with diabetes, it may be the only symptom of an acute myocardial infarction. I'm reminded of yet another case when I talk about this. This was a patient seen more than 25 years ago when I was at the university hospital. The 75-year-old diabetic father of my orthopedic colleague. He was sitting down watching television the night before, and suddenly he was drenched in sweats. He felt a little weak, but was otherwise all right. The next morning, as we were walking down the long corridor of the university hospital, my colleague just mentioned this in passing. So I said, maybe you should get an ECG done. ECG was done and showed an evolving anterior myocardial infarction. Of course, any chest pain that is triggered by exertion or emotional stress is coronary artery disease unless proven otherwise. Female patients may have atypical symptoms. They may just present with fatigue, shortness of breath, some back pain or lightheadedness. And so, if we see a lady patient with symptoms, especially if she has got significant risk factors, we must be aware of this. Your physical examination may show you stigmata of underlying hyperlipidemia. These were pictures taken years and years ago in my patients at University Hospital, xanthelasma, tendon xanthomas. Always remember to examine the peripheral pulses, because if you have got absent peripheral pulses due to peripheral vascular disease, there's a 70% association with concomitant presence of coronary artery disease. Now, when we examine the heart, you might find an arrhythmia. It could be ventricular ectopics, it could be atrial fibrillation, you might hear a heart murmur, you might hear a gallop rhythm, all signs that the heart is in trouble. Now, when you examine the neck of the patient, always remember to examine the head and neck. We are supposed to examine the whole patient anyway. You may have the symptoms reproduced, and then you might realize that the patient's symptoms are due to degenerative disease of the cervical spine, cervical spondylosis, and the pain is actually radiated pain. The electrocardiogram, cardiac enzymes, when they are appropriate, a chest X-ray, and the treadmill test are common tests. They are affordable tests, and they are useful initial tests in the initial evaluation of patients with chest pain. The ECG should be done within 10 minutes of first medical contact. This is particularly important for those of us frontliners in general practice, in family practice, because the initial ischemic changes of coronary artery disease may not become apparent again after the first few minutes and hours. Now, these two ECGs belong to a patient of ours who was seen at our emergency room. The patient was complaining of chest pain. The ECGs were done 60 minutes apart. The ECGs were diagnosed as normal. But if you look carefully, at least V4, V5, and V6, you see subtle ST segment depression. These ST segment depressions were not subsequently seen. This patient continued to have intermittent chest pain, and when a coronary angiogram was subsequently done, he was found to have a severe left anterior descending artery stenosis. This slide was made more than 20 years ago. It shows resolution of ischemic changes in the lateral leads with sublingual nitroglycerin. Because the second ECG, you see the ST segment changes are gone. But the ECG is not foolproof, and we should not be totally dependent on the ECG. We must maintain a high index of suspicion based on the patient's history and the risk factors that the patient has got. This ECG was done in 2006 in a 27-year-old male diabetic who was running away from the police. and he developed chest pain. He was brought to our emergency room, and the ECG shows you ST segment elevation of an acute inferior myocardial infarction. We did an emergency angiogram which showed subtotal occlusion of a large dominant right coronary artery in its proximal position, which was treated successfully with angioplasty. Occasionally, the presentation of an anterior myocardial infarction would be acute left bundle branch block as seen in this ECG. Of the cardiac enzymes that are available to us, the troponin is most useful. It is the cardiac marker of choice. It is sensitive. It is cardiospecific. It gives you prognostic information. And nowadays, high sensitivity troponin will become positive within 2 to 3 hours of onset of symptoms. So it helps you in making a diagnosis quickly. This is a very relevant question to ask for those of us in general practice. When might it be appropriate to order a troponin test in general practice? Because if we see a patient in general practice with symptoms very suggestive of acute coronary syndrome, which has been present within the last 24 hours, we want to quickly refer that patient to a hospital for further investigations and management. But if the patient has had symptoms suggestive of acute coronary syndrome a few days ago, and the patient is no longer symptomatic, and the patient is considered to be low risk, or if the patient presents with atypical symptoms, then doing a troponin test in your clinic may be useful as a rule-out test. The chest X-ray should be done in all patients with chest pains. It helps evaluate for cardiac and non-cardiac causes of chest pain. This chest X-ray was done on a 36-year-old male asthmatic who developed sudden chest pain and breathlessness at work. Clinical examination did not reveal much. The ECG just showed sinus tachycardia. The patient looked a little breathless. But if you look at the chest X-ray, there's a significant large pneumothorax, which was treated with the insertion of a chest tube. This chest X-ray was done in a 65-year-old male hypertensive who complained of intermittent chest pains and effort dyspnea, which had been present for about 6 months. The blood pressure was elevated. The pulse rate was 64 per minute because he was on atenolol, and a grade 2/6 aortic regurgitation murmur was best heard in the right parasternal edge. Now, the location of the murmur in the right parasternal edge is important because it suggests that aortic regurgitation is due to aortic root disease in comparison to aortic regurgitation that commonly occurs due to valvular aortic disease of the aortic valve, where the murmur is better heard in the left parasternal edge. What the chest X-ray shows is a huge aneurysm of the arch of the aorta. Echocardiogram and CT lung subsequently confirmed a large ascending aortic aneurysm which had extended into the arch, and this patient was successfully treated with open heart surgery at IJN. Now, with the proliferation of many sophisticated tests for the evaluation of patients with chest pain, many people have questioned, is the humble, old-fashioned treadmill test still worth doing? It is common, it is virtually risk-free, and it's affordable, and it's still a worthwhile test to do in the initial evaluation of patients with chest pain. But we must know the limitations of the treadmill test. The accuracy of the treadmill test varies according to the population in which it is used to study. The sensitivity and specificity of the treadmill test improves by doing a stress echocardiogram, where in addition to the treadmill test, you also evaluate the heart with the echocardiogram. So when you do a stress echocardiogram, in addition to analyzing ECG changes, you also look for wall motion abnormalities using your echo. This is to illustrate the benefit of a stress echocardiogram. The case is a 55-year-old male diabetic who was asymptomatic. He was on follow-up, and this is a follow-up test. And what you see during the treadmill with exercise, ST segment elevation. Okay, ST segment elevation in leads V4 and V5. Now, in comparison to ST segment depression, which is the common thing that we see during a treadmill test, ST segment elevation during a treadmill test has increased sensitivity and specificity. And in this case, it suggests that there's transmural ischemia involving the left anterior descending artery. This was the echocardiogram that was done during the stress echo. You see the anterior wall is contracting well at rest. Then with exercise, you find the anterior wall becomes hypokinetic. This man had an angiogram done, and the angiogram showed severe stenosis of his proximal left anterior descending artery. Besides the basic screening tests, we have now available many tools to evaluate our patients with chest pain. We have got many means to investigate these patients non-invasively. All these tests have their pros and cons, but they have increased the accuracy with which we can determine the cause of chest pain and also to pick up underlying coronary artery disease. What is important is for us to choose the most appropriate test for the appropriate patient, and even more importantly, to institute the most appropriate therapy. Echocardiography is a valuable and essential non-invasive test in the assessment of patients with chest pain. It is not foolproof, but it will assist in confirming or excluding major causes of chest pain, especially those related to the heart. If you have got regional wall motion abnormalities, it might be diagnostic in ischemic heart disease. Aortic dissection and pulmonary embolism have specific features. This is a retired anesthetist who presented to our emergency room just before midnight complaining of chest pain. The first ECG shows hyperacute ST T-wave elevation in the anteroseptal leads, suggesting that there is transmural ischemia involving the left anterior descending artery. Her symptoms settled with the use of nitroglycerin and antiplatelet therapy, because you see in the second ECG done 30 minutes later, the ST segments are down to baseline. However, the echocardiogram shows severe hypokinesia of the mid-anterior and anteroapical segments. She underwent coronary angiography, which showed severe stenosis of the proximal portion of the LAD extending to the left main stem, and she underwent bypass surgery. This was an echocardiogram done 9 years later when she was admitted for dengue fever. This is a different echo window, but serves to show that the anterior wall is now contracting very well, indicating successful bypass surgery 9 years earlier. This is Dr. Navin's case. This is a 54-year-old lady with stage 4 carcinoma of the breast on chemotherapy. On the day that she saw Navin, she had been having some chest pain, and Navin got a history of some effort dyspnea which had been present for 3 months before this. Navin tells us clinical examination did not reveal much. The ECG that you see here just shows some non-specific T-wave changes in the anterior leads. Because of her comorbidities, Navin felt that pulmonary embolism was something that has to be considered and excluded, so he asked for an echocardiogram. And here you see dilation of the right ventricle, reduced contractility of the right ventricle. And this short axis view, you see besides dilation of the right ventricle, evidence of pressure overload of the right ventricle because the interventricular septum is depressed towards the left ventricle. So CT pulmonary angiograms confirm pulmonary embolism. Navin sent the patient for evacuation of clots. And after clot evacuation, the echocardiogram now shows reduced size of the right ventricle, and you find, more importantly, you see the evidence of pressure overload is no longer there. CT coronary angiography is a major advance in the non-invasive evaluation of patients with coronary artery disease. It enables the coronary arteries to be visualized. It is currently the best test available to estimate the plaque burden in a patient and also to identify high-risk plaques. In addition to all this, during a routine CT angiogram, you'll be able to see the proximal portions of the aorta and the pulmonary arteries. And occasionally, you find that the coronary artery is actually normal, but there is disease in the aorta suggesting aortic dissection, or you might find that that's actually pulmonary embolism being the cause of the patient's symptoms. In this case, the treadmill test and the radionuclear scan was normal because there was no significant obstruction to flow in the lumen of the left anterior descending artery. But the CT angiogram showed that there's a large soft plaque surrounding the proximal portion of the left anterior descending artery. And if this plaque was to rupture, the patient could have a massive anterior myocardial infarction, which could potentially be fatal. So detection of vulnerable plaques with CT angiography will facilitate initiation of stabilizing therapy. So in a patient like this, if the patient had diabetes, you'll work very hard to control the sugars well. If the patient had hypertension, you'll work very hard to control the blood pressure well. If the patient smokes, you'll frighten him to death before he really dies. He has to stop smoking. And then you might initiate statins to bring the LDL cholesterol down to 1.8 or less. And currently, guidelines say that you must bring it down to 1.5 to make this plaque more stable and reduce the chance of it rupturing and reduce the chance of a fatal infarction. This is Dr. Yap's case. You all realize we work as a team, so we're presenting one another's case. This is Dr. Yap's case. He sent a patient for CT angiogram to evaluate for effort dyspnea because the suspicion clinically was coronary artery disease. But to his surprise, he found that the coronary arteries were normal, but there were filling defects. I think the red arrow showed it. There were filling defects within the pulmonary artery, indicating that the cause was actually pulmonary embolism. So with all these benefits, should coronary CT angiogram be the first test in all patients presenting with chest pain? There's an interesting debate in the Journal of American College of Cardiology in 2018 discussing the pros and cons of such an approach. We must remember that the vast majority of patients who present with chest pain to our emergency room have a benign cause, and it is not coronary artery disease. So if you were to do a CT angiogram for every patient who comes with chest pain, you're going to over-investigate patients, you're going to increase the cost of investigation. Of course, the chance of me changing from a Japanese car to Dr. Jayamala's Mercedes-Benz is going to increase. But that's not the reason to do things, yeah? So one of the cautions about and concerns about CT angiogram that's mentioned is that with a CT angiogram, you do not get physiological data, meaning that you see a lesion and you cannot be sure sometimes whether the lesion is significant or causing symptoms. Of course, with the newer CT angiogram programs where CT fractional flow reserve is embedded, you'll be able to get physiological data and this problem might be overcome. And of course, those of us who do a lot of CT angiograms we know about overestimation of lesion stenosis, the need for radiation, though the dose of radiation nowadays is very small, the need for contrast agents, and of course, vessel calcification, which will interfere with interpretation of the vessel lumen and the degree of stenosis. So the challenge today is, in whom should I do a CT angiogram? And how do I differentiate incidental finding versus causative disease? What is incidental finding? I see a lesion, but it might not be the cause of the patient's problem. So I'm going to try to explain this with two illustrative cases. The first patient was seen in December 2017 for the first time. He was then 32 years old. He had non-specific, non-effort related chest pains, and one of you referred him to me. There's no history of diabetes or hypertension. He smoked to glory. In his family history, his father had suffered a cerebrovascular accident in his 50s. His uncles in their early 50s needed bypass surgery. My clinical examination was normal. The treadmill was normal. The Framingham score was just 6.7%. And I told him that if he stops smoking, the score will drop to 3.3%. So we said lifestyle and sent him off. 5.5 years later, in late last year, he remained asymptomatic. He was still smoking to glory, and now he was also vaping. He saw me because he brought his business partner, who was about the same age as him, with an acute anterior myocardial infarction. So he got worried, his wife got even more worried, and they brought him for an exam. So clinical examination showed that he had actually put on weight. His stomach was now protruding. The rest of the exam was normal. The glucose was normal. His LDL cholesterol was elevated. The rest of the exam was normal. We did an ECG, and I think most of you will agree that the ECG looks quite normal. So we decided to do a stress echo. Now the stress echo showed mild ST segment depression in multiple leads at peak exercise. Now sometimes I would ignore this, But because we did a stress echocardiogram, we look at the echo part of the test, and it seems to suggest that there might be some inferior wall hypochondria. I must tell you that I wasn't very convinced. He was a fat guy, and the girls were struggling to see the inferior wall. So we said, okay, let's do a CT angiogram. The CT angiogram showed severe calcification of the ostium of the right coronary artery and the circumflex artery, and we could not interpret it. So we did a coronary angiogram, and this shows severe stenosis of the proximal portion of a large dominant right coronary artery, and we had to stent it. So this is a case where CT angiogram helped us pick up severe stenosis in a low to moderate risk patient. The second case is a 45-year-old Indian man who came to me for a second opinion. He had been having intermittent left chest pains. There was no clear relationship to effort. There was no diabetes. His blood pressure was labile and he was not on treatment. He was a non-smoker. The family history of first cousin needed coronary angioplasty at the age of 55 years. Clinical examination was unremarkable except for slight increase in weight and a diastolic blood pressure of 90. He had been investigated and managed in another center where ECG was said to be normal, a treadmill was said to be normal to stage 4 bruise. But in spite of that, he was advised to have a CT angiogram. The CT angiogram showed a calcium score of 60, which is not very high, but perhaps he's 45 years old, you have to pay some attention to it. The angiogram was interpreted as showing 70% stenosis in the LAD. So he underwent angiograms, which I saw. In my opinion, I did not see anything very significant, but the cardiologist who was looking after him decided to stent it. Now the problem was this: the patient was no better. He continued to have pains. Now the pains were going down his arm, and there was no clear relationship to effort. When you dig into his history, you find that 10 years earlier, he had had a whiplash injury during a motor vehicle accident. Now, during clinical examination, there was some limitation to movement of his neck, and when we moved his neck, the pain to his chest came back. So the rest of the exam was normal, so I thought this might be something related to cervical spondylosis. I got my rheumatologist, Dr. Ravindran Ramachandran, to see him, and Ravindran rang quite excited to say, hey, this man has got hypoesthesia over C5 and C6, and he proudly pointed out that I had missed it. Bad clinical exam. So because of this, an MRI of cervical spine was done. Unfortunately, we couldn't find this man's MRI to show you all, but this I got from the web and looks quite similar to what the man had. You see these indentations, so there's some disc prolapse, and this is cervical spondylosis. Diagnosis was confirmed. The patient received physiotherapy. He got a cervical neck collar and a short course of NSAIDs. After 1 month, the patient became asymptomatic. There are two important points in the abstract of this article. One, cervical angina or radiated pain down the chest due to cervical spondylosis has been widely reported as a cause of chest pain but remains under-recognized. And it is also shown that patients with this condition, there's always a delay in diagnosis, and in the interim period, they undergo a lot of cardiac investigations and sometimes inappropriate therapy, as we saw in case 2 just now. We do not want to miss a diagnosis of coronary artery disease, but we must be aware that other conditions can have similar presentations. And where we can, we should try to avoid doing unnecessary tests, and even more importantly, not institute inappropriate treatment. So we are back to the question that we started with. We have available to us today a huge armamentarium of tests available to investigate patients with coronary artery disease. On the one hand, we are better able to pick up underlying coronary artery disease, but on the other hand, we will also be picking up a lot of incidental disease, which might not be the cause of the patient's symptoms. So it's back to a good history and physical examination, appropriate use of investigative tools, and for us to give appropriate treatment. Thank you for your attention.